Buenas tardes a todos. Yo soy Luis Pruden, presidente de Fundasamín. Le doy la bienvenida a esta primera reunión de lo que hemos llamado un ciclo de debates en medicina perinatal. Para ello, hoy contamos con una conferencia que dará el doctor Nicholas Embleton, de Inglaterra, un panel reactivo integrado por la doctora Carmen Becchiarelli del Sanatorio Tamendi, Cecilia García de la Clínica de la Trinidad Palermo y el doctor Alejandro Dinester de la Maternidad Sardá. Junto con el doctor Néstor Bain vamos a coordinar esta reunión. Tenemos el placer también de que trabajen con nosotros Gonzalo Mariani y Gabriel Musante, quienes nos van a ayudar con la traducción y a su vez van a intervenir con nosotros en la conferencia. Agradecemos a todos que estén con nosotros. Sabemos que hay gente de muchos lugares de la Argentina, de Uruguay, Paraguay, Bolivia y otros lugares, y queremos que estos 90 minutos sean intensos, interactivos. La conferencia del doctor Embleton a continuación es fabulosa, y él está con nosotros ahora y va a estar contestando preguntas y participando del debate cuando termine su conferencia y la participación del panel reactivo. Yo le paso ahora el micrófono al doctor Coco Bain para que presente a Nick Embleton, y Coco, es tu turno.
Bueno, muchísimas gracias a todos por estar aquí, a Luis por darme paso para la posibilidad de presentar a Nick Johnson, que nos está apoyando para poder hacer esto. Sé que hay gente de Argentina, pero de muchos otros lugares de Latinoamérica, como por ejemplo Bolivia. Así que les agradecemos a todos estar. Bueno, creo que la mayoría de los que están acá escuchando saben quién es Nicholas Embleton. Nicholas es profesor de neonatología. El hospital de él es el Newcastle upon Tyne y es médico consultor. Además participa y coordina la red Newcastle Neonatal Nutrition y de enterocolitis necrotizante, de investigación en estas áreas. Sus intereses son el interés en el temas relacionados con la nutrición, con el crecimiento. También tiene un interés particular y ha investigado sobre infecciones, y además es una persona que se ha demostrado muy interesado y muy conocedor de aspectos éticos en el cuidado neonatal. Por otro lado, es una persona de una increíble generosidad, en el sentido de que él pone a disposición en su página y en su blog todas las conferencias que da, y cualquier cosa que uno le pide está siempre dispuesto para ayudarnos a todos los que estamos aquí a distancia. Tiene algunos defectos. Por ejemplo, es hincha del Newcastle Football Club. I'm saying, Nick, that you are a fan of Newcastle Football Club. Y ahí tuvo ocasión de ver a algunos argentinos, los que les gusta el fútbol, de las y los que están escuchando, saben a lo mejor que ahí jugaron Federico Fernández, Fabricio Colocini, Jonás Gutiérrez, Cristian Bacedas. I don't know, Nick, if you remember very well those Argentinian players, but you will tell us later. Y lo más importante para mí para presentar a Nick es que, conociéndolo personalmente, es un gran tipo. Es un ser humano excepcional. Así que vamos a tener el placer de escucharlo. Nick, I'm only saying bad things. We, Luis and me, only said bad things about you, so we are ready to start listening to the conference. Adelante, empecemos con la conferencia de Nick.
Well, thank you very much for inviting me to give a talk to your online conference. I'd like to thank Professor Néstor Bain, who's invited me. My name's Nick Embleton. I'm a neonatologist based in the north of England in Newcastle. And I'm going to be speaking for the next half hour or so about starting and increasing enteral feeds in preterm infants. So by way of introduction, just to explain about our research program here in Newcastle, we've got a very broad program of research. We've been involved in lots of collaborative randomized trials. We're particularly interested in the gut microbiome and metabolome. We've got studies looking at bacteriophage in breast milk. We're very much focused on necrotizing enterocolitis and understanding gut immunology. And we've also developed some mini gut organoids, enteroids, which we create from gut tissue that is salvaged after operation. We also have research programs looking at long-term metabolic outcome, and we have the Great North Neonatal Biobank, which is organised by Dr. Janet Berrington, and in that we have over 1,000 babies' samples, including stool, urine, and salvaged blood. So we have tens of thousands of samples that are important for our research program. And Newcastle, you see here, is a beautiful city on the northeast of England, and we're famous for our beer and for our football team that is very exciting to watch but never win anything, and we have a beautiful coastline and castles. So the overview of the talk: many of us work in hospitals where nutritional practice is suboptimal, and this unfortunately increases the risk of worse outcomes, both short and long term, and all of us can do better. And I'm going to cover today the evidence base for how to start enteral nutrition, talking a little about oral pharyngeal colostrum and trophic feeds, how quickly to increase feeds in babies, nasogastric or orgastric, tubes, bolus, continuous, etc. And if you want, you can visit our website, www.neonatalresearch.net, and you can find a copy of all our talks and contact us through that website if you'd like to. And the starting point is to recognize that nutrition involves more than simply nutrients. All of us are aware of the importance of providing preterm infants with appropriate protein and energy, the importance of micronutrients, zinc, iron, selenium, all these things. But that's just one element of nutrition. We also need to be aware of the functional components, human milk oligosaccharides, growth factors that you might find in breast milk, the importance of enzymes, lipases that are also in breast milk. And over the last 10 or 20 years, all of us have appreciated the importance of microbes in the gut. So these are microbes that are required and promoted by breastfeeding, but also acquired from the NICU environment, and the importance of probiotics in reducing NEC. And the fourth element of nutrition are the technical or the socio-behavioral aspects, lots of very important aspects here. So this may involve whether you give the feeds by bolus or continuous, but importantly, the role of skin-to-skin contact in promoting breastfeeding, perhaps sensory issues, how the milk tastes to the baby, but also beliefs and behaviours amongst staff. So those are the four elements of nutrition. Now, this is really critical for preterm babies because brain growth in early life is very rapid. Unlike most other primates, the rapid period of brain growth in humans occurs in the last trimester and the first few months after discharge. So that between 24 weeks and 2 years of age, humans acquire about 85 to 90% of their final adult volume. And the brain really is what distinguishes humans from every other animal on the species. If you look here, you'll see the rhinoceros with a big head, but actually with quite a small brain. And in contrast, in humans, the brain fills the entire cranial cavity. Another way of looking at it is to compare body weight against brain weight. And you'll see on this graph here that most animals plot out somewhere along that average line. But in humans, the brain is about 10 or 20 times as big as in every other species. And not only is a lot of the brain volume required in this critical period between the third trimester and 2 years of age, but there are lots of different neuronal processes going on, neuronal migration, which is particularly active in the second and third trimesters, apoptosis, the programming of cell death, synaptogenesis, which may not complete until 1 or 2 years of age, and myelination, which probably progresses until our second decade. So lots of varying processes taking place, and lots of these are under control of growth factors, particularly IGF-1. And work over the last few years or so has shown how important then macronutrients might be in promoting IGF-1 and having a direct impact on brain development. So the brain is the most important focus of all of our neonatal care. And I just want to quickly touch on the different ways in which nutrients may impact on the brain. Of course, we need nutrients to provide tissue to actually provide the substrate to grow new tissues. This is obviously all your macro and micronutrients. But then we need energy to drive the system. So this is carbohydrates and lipids particularly. But if you don't provide enough of those, you will catabolize your own protein. Then we need to recognize the role of signaling and growth factors. So in the milk fat globule membrane, this is the membrane that wraps around the triglyceride core in breast milk. Lots of different proteins and enzymes, particularly sphingomyelin and phospholipids, but also emphasizing the importance of growth factors like IGF-1 and epidermal growth factor. Next, we need to recognize the importance of nutrients in modulating gene expression. So lots of nutrients do this, but this is particularly important for folate, B12, iron, docosahexaenoic acid, and choline. The fifth way that nutrition may impact on brain development is by preventing disease, and all of you will recognize the importance of breast milk in reducing NEC and sepsis. And NEC and sepsis are particularly bad for the developing brain. So preventing those diseases by the use of breast milk is another mechanism by which we can improve brain outcomes in our babies. And then the final element might be the role of gut microbes and metabolites. And we're starting now to recognize the important role of oligosaccharides, lactoferrins, and probiotics in promoting gut health and, again, avoiding disease. So lots of different ways in which nutrition may interact with brain development in preterm babies. So this is a picture from one of the rooms on my NICU, and a baby you can see there just admitted. And just stand back and look at the complexity of neonatal care and all of the things that we talk about on the ward round every day. Whether the baby is jaundiced or needs phototherapy, whether we should put central lines in, how much fluids to give the baby, what sort of inotropes, where to keep the oxygen saturation, what's the optimal level of blood pressure in a preterm baby, should we screen for infection and start antibiotics, and how long should we give antibiotics for, what about the blood gases, temperature, urine output, ventilation. So neonatal care is really incredibly complex. And when you think about the importance of nutrition and you look at all of that equipment and all of that thinking on the ward round, you realize that most of the focus is on cardiorespiratory care. And there's a real lack of focus on nutrition, particularly in the first few days. And so nutrition is often neglected in many NICUs. Now, when I first started studying this, I imagined that the intestine was this big long tube that you tip milk in at the top end, and you suck out your fluid and nutrients, and then you produce waste product at the end. And that was honestly what I thought milk was about 10 or 20 years ago. But more recently, we've started to recognize the key importance and the interaction with all the different biochemical elements, particularly the role of metabolites and microbes, which we're going to talk about, but also immune interactions. So nutrition is more than nutrients. Breast milk is more than food. And when we're thinking about starting enteral nutrition, we need to have this holistic view of what nutrition is about. So I'm now going to move on and talk about the different elements of starting and increasing milk feeds in preterm infants. I'm going to talk a little bit about when we should give the first milk. Should we delay milk and give trophic feeds before we increase them? When we start them, how quickly should we increase? What should we do if we haven't got any breast milk? Should we use nasogastric or orogastric tubes, continuous or bolus feeds? what are the various supplements and fortifiers we should use, and when should we start them, and very briefly just touch on the role of probiotics. So let's start at the beginning. And the beginning and the importance of nutrition really needs to start before women are pregnant. We need to focus more on educating and training our staff, but also parents to be. We need to be advocating for raising the importance of nutrition in society, teaching at school and making children aware of the importance of good nutrition. And then in the hospital, we need good policies, practices and guidelines. We need to be conducting regular audit. We need to support research to improve the evidence base. We need the right resources, don't we, to provide the nutrition to the babies. We need to think very carefully about our beliefs and behaviours and our attitudes towards providing nutrition to these babies. So that's where it starts. So what about oropharyngeal colostrum? I'm not sure how many of you currently provide oropharyngeal colostrum, but we've been doing this for a number of years now. And when we first started, up in the top right picture here, we used to just put a bit of colostrum on the end of a cotton bud, and we just wipe it in the baby's mouth. But we realized that we lost a lot of the colostrum as it got sucked and absorbed in the cotton. So we now show mothers how to hand express and use a very small syringe to pick up the droplet of colostrum and then put it into the cheek of the baby. And this can even be done by the mother, and she can feel that she's breastfeeding her baby right within the first 24 hours. So if we just think about our little scheme for how we think about nutrition in the green bit, oropharyngeal colostrum actually is not providing very many nutrients at all. The really important bit is in the yellow, where we can think about how breast milk components may interact with immune tissue in the pharynx, tonsils, and may stimulate the immune system. We know that oropharyngeal colostrum will change the oral microbiota. Maybe this will prime the lower gastrointestinal tract. But also blue, thinking about the social, behavioural aspects of feeding. This may improve maternal bonding, may help the mothers feel more involved, but it may also have important aspects for the baby. Maybe the baby enjoys the taste of the milk, or it provides some comfort. So last year there was a Cochrane review looking at oropharyngeal colostrum. There are 6 studies summarised there, and overall all of these studies have actually been pretty small. So there's no real consistent effect on preventing neck or sepsis from the current studies. It does seem that maybe it improves time to full feeds if you give oropharyngeal colostrum, but there are no really big studies there at the minute. So the real effects currently are unclear, and there are some large RCTs underway. And as I say, although we might be interested in neck and sepsis, we need to think about the wider benefits, perhaps the impact on oral microbiota, but also the impacts on the mother. Our own practice is that we will start colostrum as soon as it's available, often within the first 0 to 12 hours if we can get it. And at the minute, I find it difficult to think of a major downside to using oropharyngeal colostrum. So I'm not even convinced that we really need to do these large scale studies. So once you start again with the colostrum, should you then give trophic feeds for a few days before you increase them? Well, trophic feeds or minimal enteral nutrition describes giving small volumes of milk, typically less than 20 or 30 mils a kilo a day. And the intention of this is to prime the gut rather than actually provide nutrients. When you think about it, there are lots of different study designs that have been conducted looking at this. You could either compare giving nothing, 0 feeds, against trophic feeds, or you could design a study comparing trophic feeds to increasing feeds, or you could compare a study of giving 0 feeds to increasing feeds. So there are lots of different study designs, and when you look at the meta-analysis, you realize that everybody has their own idea of what we should study. But the important point is that in the Cochrane systematic reviews, there are no adequately powered trials really looking at neck or sepsis. So there isn't any good evidence that trophic feeds is better than either fasting the baby or just increasing. Our own practice is that we increase milk feeds when mother's own milk, mom, is available, and typically that's sometime around day 1 to day 3. If we haven't got any mother's milk, what do we do? Well, I think it's important not to let the babies starve or go nil by mouth for more than about 48 to 72 hours. Very important to have careful discussions with the mothers so you don't create negative impression if you have to use formula or something else. And I think there's a general tendency to start a bit earlier if there's donor milk available compared to using formula. What about high-risk infants, so those preterm infants with in utero growth restriction or absent or reversed end-diastolic flow? Is it safe to increase feeds in those babies? Well, this was the topic of a large randomized trial in the UK called the ADEPT trial, which recruited babies less than 35 weeks, or those with absent or reversed end-diastolic flow. And this was the first collaborative feeding trial in the UK conducted, and it compared starting feeds on day 2 to starting later on around day 6. But once feeds were started, they were both increased at the same rate in both groups. So the graph here shows the difference between the two arms of the trial, with most babies in the early feed starting on day 2 and most in the late group starting on day 6. The early feeding group were a bit less likely to receive mother's milk. Only 77% started with mum's milk compared to 89%. Maybe not surprising, the mums have had a bit more time to establish lactation in the later group. And this was an intention to treat trial, so there's likely to be a bit of variation. However, you can see there's clear separation between these two groups, and overall over 400 babies were studied, making it quite a large study. And the key finding is that achieving full feeds was more quick in the early group. So the early group established full feeds at 18 compared to 21 days in the late group. So they required much less PN. No difference in the rate of neck, 15%, no difference in stage 3 neck. Babies in the early group had less cholestasis and required fewer days of high dependency care. So my interpretation of that is there's no reason to delay starting and increasing feeds, even if you are a high-risk infant. So what do we do? As I said, we tend to wait 24, 48 hours until we have sufficient mum's milk available before we would start increasing, but we need to recognize that every baby is different. And there may be some babies where you don't want to start increasing feeds straight away. So what are those babies and what factors make that decision? Well, people talk a lot about babies with poor feed tolerance, but I'm honestly never really quite sure what people mean when they talk about this. It's a very poorly defined measure. We know that routine measurement of gastric aspirates is not particularly helpful. You know, most of your babies will have distended abdomens in any case. But I suppose if I had aspirate volumes that were much larger than the amount of milk that I give them in the last 2 to 3 hours, I might be tempted to go a bit more slowly. The trial data tells me that even if the baby's IUGR, I doesn't need to make any different decisions, so I treat all the IUGR babies just the same. If the baby had a very large patent duct, so if they had a very significant precordial heave, or you did an echo and you see mesenteric steel, or you've got a big heart, I might go a bit more slowly when I increase the milk. Certainly if the baby's on more than one inotrope, if they've got unstable blood pressure, I might go more cautiously, but I will still start small amounts of feeds even in babies on low dose dobutamine. And as I said, if there was a lack of mum's milk, I might wait a little bit longer until that was available. So once we started feeds, how quickly should they be increased? So as I say, it typically takes 2 or 3 days before we have sufficient mum's milk to increase. And lots of the studies have compared slower feed increases, so less than 20 mils a kilo a day compared to faster, greater than 30. Up until 2017, there were lots of small RCTs in the Cochrane database, and there really was no consensus. But importantly, none of those trials were powered for neck or sepsis or even mortality. And many of the trials didn't recruit the highest risk infants. Of course, the problem here is that there's a challenge of what you might call competing benefits. So if you go fast, you might require less IV parental nutrition, you might get less sepsis, but maybe you'd increase the risk of NEC. Whereas if you increase too slowly and you have intravenous access for longer, you increase the risk of sepsis, but maybe you would reduce NEC. So to really balance these two competing outcomes, we need to look at long-term brain outcome. So we really need a trial that looked at brain outcome in infancy to be able to balance up these potential competing effects. And this was the SIFT trial that we took part in, led by John Dorling and published last year in the New England Journal. And this was one of the largest trials ever conducted in preterm babies, certainly the largest feeding trial we'd ever done. And we recruited preterm babies less than 32 weeks, randomized to having feed increases of either 30 or 18 mils a kilo a day. So that's about a difference of 4 or 5 days to achieve full feeds. But the outcome was looking at 2-year neurodevelopment in the babies. But of course, we looked at all the secondary outcomes like NEC and sepsis. And this was conducted in more than 30 hospitals. Most of the babies were receiving mother's milk. We recruited babies from 23 to 32 weeks gestation. But we saw absolutely no effect on the rate of NEC, sepsis, or neurodevelopment at 2 years of age. And it doesn't matter whether you look at just the tiny 24, 25 week babies or the bigger babies. It does not make a difference whether you go quickly or slowly when you increase feeds. So this is what the Cochrane database looks like now. There is no significant difference between fast and slow feeds and the rate of NEC. It's possible that there may be slightly less sepsis in the faster feed group, but no impact on mortality. And when you look at the meta-analysis, you realize that the SIFT trial that we conducted represents about 70 or 80% of the statistical weight and also the total numbers of babies recruited. So how should we interpret the SIFT study? Well, I think it tells us that it is possible to do very large feeding studies. We're certainly not going to be trying to repeat this anytime soon. And what it says to you is that an average of day 3 or day 4 in these babies, in a baby who is tolerating milk, whatever we mean by that, we probably can aim to increase feeds a bit more quickly. Important to recognize that the benefits or risks may differ if you start increasing these on day 1. It also tells us that in these neonatal units, there was no increase in sepsis from 4 or 5 days of extra parenteral nutrition. So maybe that's reassuring. Maybe we don't need to really rush the babies who need to take a few more days. It also tells us that if the babies are tolerating milk, then increasing a bit more quickly doesn't increase the risk of NEC. So remember that this is a trial of intention to treat. Many of the small babies took much longer to reach full feeds. And context matters. So the risks and benefits of faster or slower feeds may be different in UK to what they are in Africa or South America or in other places. What about continuous or bolus feeds? Well, overall, I don't think it really matters that much. Bolus feeds could be given every 1, 2, 3, or even 4 hours. If you think about what the fetus does, the fetus probably swallows amniotic fluid every 10 or 20 minutes. So the fetuses are having very rapid bolus feeds, perhaps. If you do ultrasound studies, you will show that bolus feeding compared to continuous feeding seems to result in slightly better GI motility, may improve gallbladder contraction. It has small effects on blood flow we probably don't need to worry about. And you certainly lose less fat from mum's milk if you give bolus. But there are no good quality RCTs out there. I would advise that you do what works for you. We start on continuous feeds, but I think it's important then to switch over to bolus feeds when the babies are established at a few weeks of age or sooner. And it does depend a bit on nursing and parent expertise. What about nasogastric or orogastric feeds? Again, it probably doesn't make a big difference. Nasogastric feed tubes are easier to secure, they move around less, so perhaps you have less vagal induced apnea. Perhaps they induce less oral hypersensitivity or ridges in the palate. But nasogastric tubes clearly obstruct the nostril and do have a significant impact on upper airway resistance. So orogastric tubes cause less airway obstruction, but they move around a bit more. They're easier to dislodge, and they may interfere a bit more when the babies are starting to breastfeed. So overall, I would say you do what works in your NICU, depending on your staff resources and babies. In our smallest babies, so less than 1250 grams, we would always put an orogastric tube in to start, but then move it to a nasogastric tube once they want to start sucking and use their mouth a bit more. Now, all of you recognize that donor milk is a massive topic. I haven't really got time to talk about it in great detail. Donor milk is widespread in lots of neonatal units across the world now. It does seem to be associated with slightly less neck, but all the trials have been underpowered. There's no evidence that it improves brain outcome. The effect on breastfeeding duration for the mother is a little bit uncertain, and of course it's much more expensive. So although it might be better, you've got to consider what else you might want to spend that money on. Donor milk also has lower nutrient density compared to mother's milk, and babies may grow more slowly. And there's still no consensus on which babies we should give it to. Should we give it to just the very smallest babies? Should we only give it until full feeds or until 34 weeks? And also recognize that where mother's own milk use is very high, there may be pretty minimal benefit, if any, from using donor milk. So here are the Cochrane reviews that we published a couple of years ago. Does show that weight gain is about 15% slower if you use donor milk compared to formula. There's absolutely no effect of donor milk on mortality, either compared to unfortified or fortified donor milk. But there does seem to be less neck where we use donor human milk. And that's particularly true in the trials where donor milk was used as the sole diet. So if you look here at the earlier studies where donor milk compared to formula as a sole diet, there does definitely seem to be higher rates of neck if you get formula. When donor milk is used as a supplement, the impact on neck is only just about significant. So the meta-analysis for donor milk is not fantastic. There are no good trials powered for neck, no effect on mortality in 4 trials. So donor milk may not improve survival, but it may reduce important diseases. Lots of different mechanisms that may explain why donor milk is better than formula milk in these settings. Maybe to do with the nutrient quality or quantity, the amount of nutrients there. Probably very important aspects of functional components, the cells and the microbiome. And there may be some inflammatory processes that are initiated by foreign milk proteins or antigens. So what does differences look like for donor milk? So here I'm just going to show you differences between mum's milk, colostrum, mum's own milk after a month of age, and donor milk. And you'll see for the bioactive proteins, lots of these in colostrum and preterm mum's milk. Impacts decrease over time, but lots of these are lost from donor milk. Growth factor is very important in fresh mum's milk. Again, many of these are inactivated during processing. And the microbiome is largely eradicated in donor milk compared to fresh mother's milk. There are also differences in the nutrients, so higher concentrations of protein in colostrum. Macronutrient density is a bit lower in donor milk, but there's still plenty of protein and calories there. Differences in the hormones and enzymes, so things like leptin and adiponectin may be inactivated by pasteurization. But importantly, human milk oligosaccharides that are highly individual seem to be relatively well preserved in donor milk, and maybe that's one of the reasons why you might see less neck. So just thinking about our schema in the green, donor milk, great nutrient quality, but low in density. Some of the functional components may be affected by pasteurization. You've lost lots of your microbiomic elements, but it's possible that using donor milk compared to formula may promote better breastfeeding. If you haven't got enough mum's milk and you haven't got donor milk, does it matter which formula you use? Well, as you know, there are preterm formulas and term formulas. And you can also have hydrolyzed formulas, but these are often same density as term formula. But the important bit when you're starting and increasing feeds, there's absolutely no evidence of an effect on neck or sepsis, whether you use a hydrolyzed milk or whole protein milk. It honestly does not matter what you use. So if you're using formula to start feeds, I don't think it really matters which formula you're going to use. But of course, babies on preterm formula compared to term formula will grow a bit faster. Breast milk fortifier are very important in promoting growth in the very small babies. If you're feeding unfortified mother's milk, you're unlikely to meet nutrient needs if the babies weigh less than about 1250 or 1500 grams. Of course, you can give high volume milk feeds up to 220, but adding fortifier is really the easiest way of promoting growth. So these breast milk fortifiers, multi-components, protein and energies, additives with extra minerals and vitamins. The protein source is mainly hydrolyzed bovine whey. You'll know that there are some human products available on the market, but they're very expensive at the minute. The energy source generally is carbohydrate, although sometimes there's some extra lipid. And you can get these either as a powdered sachet or as liquid. But if you're using a liquid, remember that that may displace some of the breast milk volume that you're using or want to give. So breast milk fortifier does show improved growth, but unfortunately none of the trials have been big enough to show any effect on neurodevelopment at 2 years of age in these babies. And importantly, none of the trials have shown that they increase the risk of neck or sepsis, and if they are available routinely, then I do recommend using them. So human milk fortifier, really bovine milk fortifier, simple method that will provide extra nutrients, but very few functional components. May impact on the gut microbiota, and we need to be very aware of the risks of contamination. And then there are lots of other aspects of human milk fortifiers, such as cost and osmolality, what the mothers may think about it, and the risks of marketing by milk formula companies. So we're almost finished now. What other supplements should we use? Well, if you're less than 2.5 kilos, you do need vitamin D adding to the baby's diets. They should also receive supplemental iron around 2 milligrams a kilo from about 2 or 4 weeks of age, perhaps a little bit more in the babies less than 1,000 grams. And if you're not going to use a fortifier, you certainly need to consider giving the babies extra minerals, sodium and energy. So there are lots of supplements that might have an impact, but currently there aren't any data or they're not shown to work. So things like lactoferrin, human milk oligosaccharides and other prebiotics. Lots of people are looking at these, but no consistent evidence that they make a difference. We're starting to look at things like DHA and choline and milk fat globule. These may have important aspects. And there are, of course, lots of other components in breast milk that haven't yet been studied. Probiotics, I'm only going to show one slide on this. This is a very complex topic. There have been lots of trials individually. Each of these have been underpowered for neck or sepsis, but when you combine them in the Cochrane meta-analysis, the risk of neck mortality and sepsis does seem to be substantially lower if you receive probiotics. But there are lots of different concerns and risks we have. There are no good studies in low and middle income countries. Neck mainly occurs in the smallest babies. So these may not be the babies that people are treating as much. There are lots of different probiotic strains and combinations and different doses. The studies all use different populations. There are definitely risks of contamination of probiotic products with fungus, and some babies have developed septicemia with probiotics. And some of the manufacturers that provide these products, the quality control really can be quite poor indeed. So certainly if you're in a high resource setting with good quality control products, I would recommend that people consider using probiotics once feeds have been started. But in low or middle income countries, or where the quality control may be poor, I think we need more research, and I certainly would recommend taking great caution before you start using commercial products in your babies. So as I say, we need to adopt a holistic approach to nutrition when we're starting and increasing milk feeds. Mum's breast milk is key. We need to recognize the importance of empathic support and promotion and advocacy for breast milk. Importance of kangaroo care, the importance of the right NICU environment, equipment and infection control. We all need to have good guidelines, audits and policies. We need to provide the mothers with food and drink if we want them to provide breast milk, and we need training and education. But most importantly, all of us should be providing good leadership and acting as role models for all the other staff around us. And as I say, I think generally, particularly in the area of nutrition, if you want to make a difference, you probably can. So better nutrition, certainly key to improve survival, as we're looking after more and more of these babies, and more are surviving. Nutrition and understanding how to provide good nutrition to these babies becomes increasingly important. Again, just to emphasize that breast milk remains the most important and cost-effective intervention that we have available. Just here, just showing you the differences between formula milk and breast milk. So appearing there, you will see 75 different components which are added to formula milk to allow it to comply with government recommendations and meet nutrient requirements. In comparison, breast milk, of course, has lots of similar components. Of course, it has to have protein and water and fats and all these kind of things, but involves lots of other things like prostacyclins and thromboxanes, enzymes like trypsin, L-carnitine, important for fatty acid metabolism, taurine, lots of different long-chain polyunsaturated fatty acids, lots of immunoactive compounds, complement and these sorts of things. Lots of different phosphatidylcholine and phospholipid, sphingomyelin compounds that you don't get in bovine milk. Lots of nucleotides, the building blocks of DNA. Human milk oligosaccharides, you don't find any of those in formula milk. Lots of different cytokines, growth factors. I could go on and on. So here's a list of about sort of 200 or 300 different components that you will not find in formula milk, all of which are probably important in promoting health in our preterm babies. So in summary, nutrition is more than nutrients. Oropharyngeal colostrum, the evidence base is a bit limited, but I think there's good reasons to support its use. It probably doesn't matter whether you give trophic feeds or increase as soon as the milk is available. You should then be increasing your milk between 18 and 30 mils a kilo a day once it's tolerated. We should always prioritize mother's own milk at all different stages. Whether you use nasogastric or orogastric, bolus or continuous, it probably doesn't really matter that much. If you have donor milk available, you probably should be using it to start feeds. And probiotics should possibly be used in these babies. So I'm just going to finish there. Thank you very much for listening. Just to emphasize, we've got a website there, neonatalresearch.net. We're on Twitter, neoresearch_net. We'd love to hear from you. You can contact us through the website or Twitter or through email. And I'm going to finish there. Thank you very much and enjoy the translation. Hope it all works well. Thank you.
No veo. Bueno, muchas gracias, Nick, por una conferencia tan integral, holística, diríamos ahora. Has cubierto todos los aspectos interesantes, creo que esto va a dar motivo a un debate muy lindo. Yo quisiera hacer dos comentarios. Primero, que creo que todas las personas que están oyendo esta conferencia y la mayoría de los pediatras y neonatólogos argentinos estamos muy comprometidos con la alimentación con leche materna, y todos los servicios de neonatología que trabajan bien le dedican enormes esfuerzos a obtener esta leche materna. Y esto es difícil en algunos lugares, por razones de enfermería, por razones de cantidad de bombas, de extracción, pero es una meta que todos debemos cumplir. No hay ningún otro método, ni suplementación de leche, ni bancos de leche, que reemplace el esfuerzo continuo de nosotros para hacer que las madres de nuestros propios chicos se extraigan leches. Y para eso, cuando podemos, debemos comenzarlo en la etapa prenatal. Quiero hacer un pequeño comentario y un homenaje, que es al Servicio de Neonatología de la Maternidad Sardá, liderado en su momento por el doctor Alfredo Larguía, pero con los jóvenes Miguel Larguía, Alejandro Donel, José Seriani, Jorge Martínez, Juan Carlos Buscaglia, Osvaldo Stoliar, que hace 50 años, fines de la década del 60 y comienzos del 70, comenzaron a usar calostro en vistas de una epidemia o epidemias que había de diarreas por gram negativos. Este llamado pan calostro fue pionero. Esto no fue seguido y realmente pasaron muchos años hasta que los neonatólogos empezamos a usar alimentación trófica, llamada así, porque habitualmente en todos los intercambios que teníamos con gente de todos lugares del mundo nos decían que dar alimentación temprano era malo, que había más enteritis necrotizante, etc. Desgraciadamente, en ese momento no se pudo hacer un estudio aleatorizado, que hubiera sido lo que todos hubiéramos querido. Intentamos de algunas maneras. Dos dificultades. Una, no teníamos en ese momento la técnica de hacer jeringas opacas, y por otro lado, la firme convicción del servicio de los beneficios del calostro hacía muy difícil encontrar lo que se llama equipoise, o duda balanceada, o duda genuina, lo cual hace difícil en un lugar donde hay una creencia tan fuerte hacer un estudio aleatorizado. No obstante eso, creo que esa experiencia quedó como una experiencia que marcó a todos nosotros y que creo que fue pionera, desgraciadamente no difundida a tiempo para que esto fuera generalizable en el mundo. Yo ahora quiero dejar al panel reactivo, coordinado por la doctora Becchiarelli e integrado por Alejandro Dinestein y Cecilia García, que ellos van a hacer comentarios, reflexiones sobre la charla, y después van a abrir a preguntas de todo el auditorio, que esperemos que sean muchas y que el intercambio sea realmente lindo. Muchas gracias.
Bueno, muchísimas gracias, doctor Pruden. Felicitaciones al doctor Embleton. Realmente fue una charla en la cual recorrimos todos los aspectos que permanentemente a diario tenemos que enfrentarnos. Bueno, una de las primeras preguntas justamente hace mención a la importancia del plan calostro. Así que me gustaría, Cecilia, la doctora García, que haga algún comentario en relación a esto y tu experiencia en el tema, y justamente con esto, junto con el doctor Nick, vamos a responder tal vez esta pregunta.
Bueno, muchas gracias, Carmen, por la oportunidad de participar de este panel y de la conferencia del doctor Embleton. Es llamativo la importancia que él le da a la administración temprana de calostro obtenido de la propia madre, a pesar de que no hay fuertes evidencias de su instrumentación y de cómo debe administrarse, pero bueno, una gran cantidad de unidades están implementándolo. Nosotros, de hecho, estamos trabajando en esto, lo cual implica un gran compromiso de todo el personal involucrado en la obtención de este calostro desde el primer momento, y no importa el volumen. Esto es algo importante de destacar, porque muchas veces son gotitas que se pueden recoger del pecho de la madre, aún en sala de partos. Hay muchas mamás de prematuros que ya tienen secreción de calostro en el momento del parto, Y yo lo que quisiera preguntarle al doctor Embleton, ¿cómo tienen armado ellos el equipo y la instrumentación de esta modalidad de recoger calostro tempranamente y poder administrárselo a los bebés, aún sin tener un ritmo ni un volumen específico, sino lo que se obtiene, poder administrarlo, y no como función nutricional, sino justamente de imprinting, de trófico sobre el sistema gastrointestinal desde muy tempranas horas del nacimiento de estos bebés prematuros, sobre todo en los más chiquititos.
Bueno.
Gonzalo.
Bueno.
Hola, Carmen.
Hola, ¿qué tal?
Estamos ahora en vivo. ¿Qué tal? Buenas tardes a todos, a todas. Muchísimas gracias por la invitación, a los organizadores. Los felicito realmente. Bueno, es un lujo tenerlo al doctor Nicholas Embleton y escucharlo. Estábamos en la nube, así que tardamos un poquito en llegar, pero escuchamos muy bien su conferencia y también las palabras del doctor Pruden y de la doctora Cecilia García. Así que Nick está aquí, ¿verdad? Yo ahora,
sí.
Sí, okay. Hi Nick, it's an honor and a pleasure to be here with you again and listening to your excellent talk. We would like to tell you that Cecilia Garcia, she's a neonatologist working here in a hospital, very prestigious, and she was highlighting the value of colostrum, as you said in your talk, and I think you said that it is very important for not only for nutritional or trophic effects, but also for all the social component and the idea for this mother to be convinced that this is an important part of the nutrition of her baby. So Cecilia was saying that in her service, they usually talk to the mother even before the delivery, and they start trying to anticipate the importance of human milk and prepare her for the early extraction of colostrum. And actually, she was saying that in their service, they actually sometimes they get colostrum even during labor. The nurse take the small amounts of colostrum with a syringe, and then within the first 3 or 4 hours, they are providing this colostrum into the mouth of the baby, even if the baby is on mechanical ventilation or CPAP. So she would like to ask you, how do you organize this in your unit? How is the breastfeeding program concerning the administration of colostrum? Which are the people that is involved in this? How do you manage? Do you get early colostrum? Does it matter the volume that you get to start feeding or to start giving colostrum to these babies?
Yes.
Just a second, Gonzalo and Nick.
Yes.
My name is Gabriel Musanti. I'm going to translate your answer. So if you could just pause after each sentence or paragraph, or just to allow me to translate on the way. Thanks.
So thank you very much to Nestor and all of you for inviting me. It's wonderful to be able to interact with you. We are not as good as we think we should be. When you hear people like me speak, I think you imagine that we work in hospitals where everything is perfect, but we have all the same problems that you do.
Sí, básicamente dice que más allá de todas las cosas que hacen, él lo que nos quiere comentar es que aún allá todavía no son tan buenos haciendo esto como quisieran y que tienen problemas parecidos a los que podemos tener todos acá.
So we have 2 nurses whose job it is to help mothers provide breast milk, but the nurses only work normally in the daytime, not in the evening and not at nighttime.
Tienen 2 enfermeras que se ocupan específicamente de ayudar a las madres para prepararlas para sacarse calostro y para instruirlas en este aspecto, pero solamente trabajan durante el día y no hay nadie que se haga cargo de esto, por ejemplo, durante la noche.
So we must teach the residents, the fellows, and the nurses how to speak to these mothers, especially if the baby is born in the evening or at nighttime or something like this.
Entonces lo que hacen es tratar de transmitir este conocimiento y enseñarles a sus residentes, a sus becarios o fellows y a las otras enfermeras que no son especializadas, cómo hablar con estas familias, especialmente durante la tarde o la noche o fines de semana, cuando tienen que prepararlas de la mejor manera posible.
One of the most important things is to encourage the mother to start hand expression, using a hand to massage the breast in the first few hours. If people don't speak to her, then the temptation is that she may go to bed and not do anything until the next day. So we emphasize the importance of starting hand massage in the first few hours.
Una de las cosas más importantes que ellos hacen y enfatizan es siempre deben estimular a las madres a que comiencen con la expresión manual temprano, de que empiecen en las primeras horas de vida, cuando quizás si no hay alguien que indique esto, que estimule que esto ocurra, puede ser que lo dejen para más adelante, que estén cansadas y que recién empiecen a hacer expresión manual o estimulación manual de la salida de calostro, de la bajada de leche, recién al día siguiente.
And we made up some packs just with a plastic bag. And in the plastic bag, we put an information leaflet and some small syringes to collect the milk and some little pots for the milk and an information leaflet. And on the information leaflet, there is a QR code, and the mother can shine her phone at the QR code and it takes her to a little video that tells her about colostrum and how to provide colostrum.
Una herramienta que prepararon es que tienen preparado un pack, una bolsa de plástico en la cual tienen fundamentalmente un folleto informativo, pequeñas jeringas, contenedores y en ese folleto también un código QR para que las madres puedan ingresar con su propio celular y acceder a información en forma de videos o en forma de gráficos mediante ese código QR con su propio celular.
So I say to the residents and the fellows, when you finish putting the endotracheal tube or the umbilical line and you ring for the X-ray, then you must take this plastic bag to the mother, tell the mother that the baby is okay, give the plastic bag to the mum. You don't have to pretend you're an expert in breastfeeding. You just say, this is really important. We need to help you. You get the nurses, but we make sure that we try and start that very early after the baby is born.
Entonces lo que le dicen a sus residentes y a sus becarios es que cuando terminan de poner el tubo endotraqueal, los catéteres umbilicales y cuando confirman la posición mediante la radiografía, que tomen la bolsa de plástico, vayan a hablar con las madres y que se la entreguen. No necesariamente tienen que ser expertos en lactancia y darle toda una charla demasiado profunda sobre lo que es lactancia, sino que con solo darle la bolsa y cumplir con ese objetivo, consideran que es lo más importante para que esto ocurra, especialmente en las primeras horas.
It's very important, especially for doctors, to recognize the power and the authority that we have. So when a doctor says to a mother, breast milk is really important, they know that we are here to look after their very sick baby in the NICU. So it's especially important that doctors are involved in talking to the mothers. We must not leave it just to the nurse or the lactation consultants. We have to show leadership and show all of our colleagues and the mothers that we really believe this is important.
Lo que resalta el doctor Embleton es que tenemos que ser conscientes del poder y autoridad que la comunicación de parte del médico tiene con respecto a las familias y a las madres, que tenemos que tener conciencia de que cuando un médico le dice a una madre de un bebé prematuro que darle su propia leche, darle leche materna es muy importante, teniendo en cuenta que es la persona que lo cuida en una terapia muy avanzada y muy compleja y muy tecnológica, bueno, que es importante también que esa misma persona que tiene ese rol y ese lugar transmita, se involucre y que tenga un rol de liderazgo, no solamente hacia los colegas, sino también junto con las madres, sino dejar eso solamente en las enfermeras y en las consultoras de lactancia o las puericultoras.
Okay.
Muchas gracias. Bueno. Muchas gracias por la respuesta y realmente es tal cual como él lo menciona. Todos tenemos que tomar participación, pero el rol del neonatólogo, como de pronto el que coordina toda la atención de ese bebé prematuro, transmitirle a la madre la importancia de esto como si fuera un medicamento o un equipo tecnológico, realmente. Muchas gracias, doctor Embleton.
Muchísimas gracias. Gracias también Gaby y Gonzalo por esta ayuda. Y doctor Embleton ha contestado en esta pregunta, ha contestado muchísimas de las preguntas que nos están llegando, así que en parte con esto resumimos muchísimas de las preguntas que llegan, pero dentro de estas quiero señalar la consulta en relación a la utilización y a la utilidad de la leche de banco. Así que en eso, Alejandro, que estás trabajando tanto en Sardá en relación a esto, quería saber tu opinión y de paso la pregunta al doctor Nick Embleton. Gracias.
Sí, yo más que hacer una pregunta en este momento, tengo preguntas que las voy a hacer más adelante durante el desarrollo de esta reunión. Yo lo que quería es hacer dos comentarios de algo que a mí me ha despertado escuchar esta excelente conferencia. Es un placer, Nick, escucharte nuevamente. Nosotros leemos las guías, las normas, todo el mundo lee todo. Lo que pasa es que no siempre leemos a nuestros pacientes, no siempre vemos qué es lo que el paciente necesita. En un aspecto como la nutrición enteral, donde hay tanta divergencia, donde la evidencia no es de la mejor calidad posible, yo creo que lo que tenemos que tener es un abordaje individualizado de nuestros pacientes. Tenemos que ver dentro de todas las alternativas qué es lo mejor para cada paciente y en qué momento. Y a lo mejor lo que es mejor hoy no es lo que es mejor mañana. O sea que tenemos que tener la habilidad de ver, de ser clínicos, de ser semiólogos, de ver a nuestro paciente y elegir en cada momento qué es lo mejor. No empecinarnos porque una evidencia de no muy buena calidad dice una cosa u otra dice la otra. Creo que tenemos que pensar al lado del paciente permanentemente. Bueno, Gonzalo, si querés hacer otro comentario, perdóname.
No.
Okay. Me habías dicho que acá
Está muy bien, muchas gracias. So Nick, Cecilia was saying thank you to you for your complete answer, and she completely agree with the importance that we as doctors get involved in this message and train not only our training people, but also all the people in the NICU, and talk with the mothers that it's going to be very, very important. So then Alejandro was mentioning that he was amazed by your excellent talk. He said something interesting for me, at least. He says that as well as we know how to read clinical practice guidelines, for example, we have to learn to read our patients. What do they need in different moments of their lives? So, and particularly in this issue of enteral nutrition, in which the evidence is not conclusive, he thinks, and I agree, that an individualized approach is mostly a very good alternative. As you said in your talk, one size does not fit all, right? So that was his comment, Alejandro. If you have a question, or Nick, if you would like to comment on this, of course.
Well, I mean, you're right. We need to treat each baby as an individual. We have to have guidelines that give us, some guidance normally. But you're right. I mean, every baby is different, and we do need to appreciate that for sure.
Thank you. Ale.
Sí.
Bueno, teníamos que traducir, ¿no?
Gabriel.
¿Querés vos, Gabriel, o...? Bueno, básicamente mencionó que está de acuerdo con el comentario de Alejandro y que es importante tener guidelines, pero que también aplicarlas en forma individualizar la aplicación, mejor dicho, de las guidelines, porque no todos los pacientes son iguales y no todos los pacientes en distintos momentos de su devenir, de su vida, van a requerir lo mismo, ¿no?
Perfecto. Ale, ¿querés comentar algo de los bancos de leche?
Quería hacer un comentario simplemente que yo creo que es importante tener bancos de leche que son útiles, que a nosotros nos permite alimentar exclusivamente con leche humana a todos nuestros prematuros menores de 32 semanas, pero que no hay que confundir cuál es el foco. El foco tiene que ser alimentar a los chicos con leche humana, con leche de su propia madre. Es una herramienta más que tenemos, pero no podemos pensar que logramos que es un éxito alimentar a los chicos con leche humana cuando no hemos hecho todo, empezando con el calostro precoz, con hablar con la madre, con todo lo que dijo recién Nick. O sea, entender qué es lo importante y cuáles son las herramientas para lograrlo. Y una pregunta, y con esto ya termino, en relación a la leche de banco y a la leche de la propia madre, y con respecto a probióticos que pasó en una diapo el doctor. Mi duda es si en pacientes alimentados exclusivamente con leche de su propia madre, el aporte de probióticos exógenos no podría modificar el desarrollo de la microbiota. Si la microbiota ideal no es la que va a desarrollar alimentado con la leche de su propia madre, y sí estoy de acuerdo en fórmula, en pacientes con leche humana donada, pero pacientes alimentados con leche de su propia madre, a mí me gustaría saber si en esa población también probióticos o los probióticos de la propia leche de su mamá son suficientes como para no dar otros.
Muy bien, gracias Alejandro. Gabriel está con un problemita de conexión, así que vamos a tratar de seguir. Nick, Alejandro was saying that they have a milk donor bank in their unit, and he thinks it's really important for nutrition, but the goal shouldn't be to have a bank, a milk bank, but to support and develop a program to increase maternal milk production and maternal milk feeding for the babies. So he was saying that probably the objective shouldn't be to have a bank, but to have this as a transient practice while they work in achieving higher feeding with maternal milk. And he has a question. The question is referred to patients that are fed predominantly with milk from their mothers. In those babies, he would like to ask you, could the contribution of probiotics, of industrial probiotics, modify the development of microbiota in babies that are predominantly fed by maternal milk?
So the question is whether probiotics are as effective in mothers with mother's milk, or?
Well, if you think they could modify or alter the development of the microbiota in those babies that are fed mostly with maternal milk.
Yeah. We all need to recognize that the microbiome that you acquire in the first few days or weeks of life may have long-term impacts in the future.
Debemos reconocer que el desarrollo del microbioma en los primeros días de vida puede tener impacto alejado en la vida del paciente.
Yeah. We know in babies born full term that are born by cesarean section, or term babies that are fed formula, we know in these babies that their microbiome is very different.
Conocemos hoy día que aquellos recién nacidos de término que nacen por cesárea o aquellos recién nacidos de término que se alimentan exclusivamente con fórmula tienen un desarrollo de microbioma bien diferente.
When we look at the microbiome in a baby at 25 weeks, it's very different to a baby born full term.
El desarrollo de la microbiota o microbioma en los recién nacidos prematuros, por ejemplo, de 25 semanas, es muy, muy diferente al desarrollo de la microbiota en los recién nacidos de término.
The effect of cesarean section does not appear to be very strong in premature babies, mainly because the remainder of their environment and the antibiotics is very different.
Dice el doctor que el efecto de la cesárea en los prematuros extremos no parece tener un impacto tan importante porque hay otros factores que están jugando un rol, como por ejemplo la administración de antibióticos en estos pacientes y a sus madres.
When we have a premature baby and we're giving that baby mother's milk, if we give a probiotic, for certain we are changing that baby's microbiome.
Si tenemos un prematuro que está tomando leche de madre y le damos también probióticos, estamos generando un cambio en el desarrollo de su microbiota, seguramente.
And at the minute, we do not have any data to tell us whether that will have any impact in 10 or 20 years' time.
Actualmente no tenemos ninguna información sobre el impacto que esto puede tener de manera alejada, 10 o 20 años por delante.
However, most of the trials of probiotics in premature babies have included a lot of babies who were only getting their mother's milk.
Sin embargo, la mayoría o muchos de los estudios que estudiaron la administración de probióticos en recién nacidos prematuros incluyeron dentro de su población a prematuros que estaban recibiendo exclusivamente o mayoritariamente leche de madre.
Yeah. And when you look at the meta-analysis for probiotics, there is a clear reduction in NEC, sepsis, and mortality.
Y cuando uno mira el metaanálisis de los estudios de probiotics, se ve que hay un efecto marcado de disminución en enterocolitis necrotizante, sepsis y mortalidad.
There is no other intervention I know in neonatology that has such a dramatic impact at present.
En el presente no conozco, dice el doctor Embleton, otra intervención que tenga un impacto tan dramático en el outcome, en los resultados de los prematuros como este.
So I accept that probiotics will change the microbiome in a baby getting mother's milk, but for me, the biggest risk is the baby dying from necrotizing enterocolitis. So that's why we have used probiotics now for maybe 8 or 10 years.
Acepta que puede haber un impacto sobre el desarrollo de la microbiota de los prematuros, sin embargo, para él es mejor jerarquizar que los recién nacidos que los reciben tienen protección sobre estas enfermedades como enterocolitis y sepsis, y por eso es que ellos los están usando desde hace 8 o 10 años.
And if I asked the mother what she would want, and I showed her the data, I do not think she would be worried about the longer term microbiome in her baby. She would want me to do the best thing now. So, yeah, I understand the concern, but for me, probiotics seem to be a very safe and effective treatment in our country, at least.
Dice que si uno le preguntara a las madres qué piensan acerca de la administración de probióticos en función de los resultados de los estudios, probablemente coincidiría en que la importancia de los efectos en ese momento y no tanto poner énfasis en lo que pudiera llegar a pasar en forma alejada. Así que, digamos, por eso es que esto, ahí me olvidé la última parte de la respuesta, pero básicamente eso, ¿no? Que fortalecer los beneficios a corto plazo parecen ser tan relevantes que entiende, él dice, la preocupación con el desarrollo de la microbiota, pero parece puesto en la balanza, digamos, algo menor a los efectos beneficios.
Bueno.
Muchas gracias.
Bueno, muchísimas gracias. Continuando entonces con las preguntas, doctor Embleton, usted que ha sido pionero y que nosotros lo tomamos siempre de base con la descripción de la restricción de crecimiento extrauterino en los bebés prematuros, ¿qué estrategia nos sugiere en la etapa de transición entre el cambio de la nutrición parenteral hacia la nutrición enteral, en especial en los prematuros extremos, para evitar otra etapa más de restricción del crecimiento?
¿Querés que la traduzco yo, Gonzalo?
Dale, gracias.
Considering that you have been a pioneer and have been studying the impact of UGR on feeding and nutrition and posing difficulties on feeding these babies with IUGR, Dr. Becchiaretti would like to ask you, which strategy do you suggest regarding the moment of transition in these babies with IUGR or babies that are probably a little bit sicker than other babies, the transition from parenteral nutrition to enteral nutrition, and how do you go over this transition period or this transition scenario in order to avoid another potential moment of malnutrition or subnutrition when you're dealing with the change from parenteral nutrition to full enteral feeds?
Yep. My unit has 150 nurses and 20 doctors. So I have to devise guidelines that are simple enough for people to follow, even if I'm not there.
Perdón. Cuenta el doctor que en su unidad tiene 150 enfermeras y 20 neonatólogos, y por lo tanto es mejor desarrollar normas o guías de práctica clínica que sean lo suficientemente sencillas para que todos las puedan seguir, entender y seguir, y no tener que estar personalmente con cada paciente.
We have a standard bag of PN that we keep in the fridge. So all babies less than 1,500 grams start on a standard bag of PN when they first come to the unit. And we start that at 100 mils per kilo a day.
Ellos tienen preparadas y disponibles bolsas de nutrición parenteral estándar y en todos los pacientes menores de 1.500 gramos colocan desde el primer día, de las primeras horas de vida, esa bolsa de nutrición parenteral estándar a 100 mililitros por kilo día.
We increased to 125 and then 150 over the next 2 days. And by day 3, most of our babies will be getting 150 of PN and maybe a little bit of colostrum.
En los días siguientes, al inicial, que había dicho que comenzaba con 100 mililitros por kilo, van ascendiendo el aporte a 125 y 150 mililitros por kilo en los días 2 y 3 de vida. Y entonces al tercer día de vida, en general, los prematuros están recibiendo un aporte de nutrición parenteral de 150 mililitros por kilo y para ese entonces ya también tienen aporte de algún volumen de calostro.
We then start increasing the milk if we have enough mother's milk. And when we start, or the baby starts to tolerate round about 20 or 30 mils per kilo a day, we start to decrease the PN.
Comienzan a aumentar gradualmente el aporte de leche humana en la medida en que haya disponible y cuando el recién nacido alcanza 20, 30 mililitros por kilo es cuando comienzan el descenso gradual de la nutrición parenteral.
So by day 4 or 5, baby will be on maybe 125 of PN and 25 of milk. And then we keep decreasing the PN and increasing the milk 1 mil for 1 mil.
Entonces al día cuarto, quinto de vida, los pacientes prematuros están recibiendo aproximadamente 125 mililitros por kilo de nutrición parenteral y 25 por kilo de leche materna, y a partir de ahí hacen el descenso gradual de la parenteral y el aumento gradual de la nutrición enteral, mililitro a mililitro.
So we keep the PN running until the baby is tolerating 150 of milk.
Y continúan con nutrición parenteral hasta que el recién nacido tolera un aporte enteral de leche de 150 mililitros por kilo.
And then we routinely increase to 175 in all of our babies. And when they then tolerate 175, we start breast milk fortifier at that stage.
Luego continúan subiendo hasta alcanzar 175 mililitros por kilo de leche humana y a partir de ahí le agregan el fortificador de leche humana. Thank you.
Okay.
Bueno, muchísimas gracias. Bueno, ahora vamos a hacer algunas preguntitas del público, que son varias. Las vamos a tratar de compactar porque, y en general vamos a tomar los aspectos prácticos que nos pasan todos los días. ¿Qué repercusión han tenido ustedes y qué cambios han realizado en relación a la pandemia de COVID-19? Otro aspecto de otras de las preguntas también prácticas es, en el caso de no tener leche materna, en pacientes con enterocolitis se utilizan fórmulas hidrolizadas y si no les alcanza en el crecimiento, si ustedes enriquecen la leche con ácidos grasos de cadena media. Esas serían las 3 preguntitas cortas principales.
¿Voy yo, Gonza?
Dale, gracias.
Sí, igual, Carmen, hagamos una por una, porque
Dale, cómo no.
preguntas es medio difícil. So there's 3 questions right now from the public, from the participants. The first one is, which changes in regards to nutrition did you apply regarding the pandemics and COVID-19 infections or infection prevention or infection control? That was the first question. The second one was...
vamos una por una, que conteste, ¿no? La primera.
Yes.
Yeah, you go ahead, Nick. Thank
you. We haven't changed anything about nutrition due to COVID. Everything is just the same. We still speak to the mothers. We still use fresh breast milk. We have had a few mothers who are COVID positive, but we have still used their breast milk and we have not had any problems.
Dice el doctor Embleton que no han hecho ningún cambio con respecto a la nutrición o al aporte nutricional de los pacientes en la unidad de cuidado intensivo neonatal a partir de la pandemia, que ellos continúan con las mismas estrategias, que han tenido algunas madres positivas para COVID, pero en esos hijos de esas madres también han utilizado o fomentado la utilización de leche de madre. The second question, Nick, was if you have a baby with necrotizing enterocolitis and you don't have maternal milk, would you suggest to use any specific formula like hydrolyzed formula?
We do use a hydrolyzed formula if there's no breast milk. I think it would be better to use donor milk if we had it. But yes, we do use a hydrolyzed milk. There is no data to show this is better. Remember that if we think breast milk is good for the baby, breast milk is whole protein, breast milk is not hydrolyzed. So if breast milk is okay, then maybe you don't need a hydrolyzed milk. But our surgeons like hydrolyzed milk, and we like to keep our surgeons happy. And because I think it doesn't matter, then I say it's fine to use hydrolyzed milk.
Bueno, la respuesta es muy interesante. Ellos usan fórmulas hidrolizadas en estos pacientes, en pacientes, digamos, que se están realimentando luego de una enterocolitis necrotizante. Usan fórmula hidrolizada a pesar de que saben que no, son conscientes de que no hay demasiada evidencia que sustente esta utilización, que quizás preferirían utilizar leche de donante, digamos, leche donada, pero no disponen de donación de leche, así que usan fórmulas hidrolizadas. Lo que dijo es que también la leche materna no tiene las proteínas hidrolizadas, sino que tiene las proteínas completas, así que es probable que no haga falta que las proteínas y que los nutrientes estén hidrolizados, pero que ellos tienen un grupo de cirujanos que les gusta realimentar a sus pacientes de esta manera y que les parece muy importante que sus cirujanos estén contentos en la NICU.
And I think the third question was about if you have a baby that is not growing adequately, would you consider to add some other components like medium chain triglycerides?
No, we don't add any medium chain glycerides or anything else. It's important to make sure that you have corrected everything that you can correct. So if you have a baby with slow growth, make sure the baby is being given enough volume. Make sure that you've fortified it. Make sure the baby has a normal sodium level. Make sure the baby's on iron supplements. But if everything is fine and the baby's on breast milk, then maybe that is an individual baby who just will grow a little bit more slowly.
Bien, no, la verdad que no usan TCM y mayormente ningún suplemento. Cuando tienen un bebé que no está creciendo lo que ellos quisieran, tratan de corregir todo lo que se puede corregir, principalmente ver si el volumen que recibe este paciente, este bebé, es el suficiente, si está correctamente fortificada la leche, si el sodio está normal, si el hierro está normal, y si todos estos controles o estos chequeos dan bien, y el bebé está recibiendo leche materna, quizás pensar que puede ser un paciente, un recién nacido, que esté creciendo de la forma que tiene que crecer y que crezca un poco más lento que otros.
It's important to remember that weight gain is a marker and not an outcome. Brain growth is an outcome. Disease, necrotizing enterolitis is an outcome, but weight gain is there to guide us. You are better having a fully breastfed baby growing slowly than a formula-fed baby growing on the centile. So the one thing we know is that breast milk is the most important thing. But if you have a baby growing slowly, but he's getting lots and lots of breast milk and is otherwise okay, slow growth is fine.
Sí, básicamente lo que dice es que el crecimiento, la ganancia de peso no es un resultado per se, sino que es solamente un marcador. Quizás el crecimiento del cerebro sería un resultado a tener en cuenta. Enfermedades tales como enterocolitis necrotizante, la sepsis, sí son resultados a tener en cuenta, pero el crecimiento es solamente un marcador, es algo que nos tiene que guiar y no un resultado per se o algo a buscar como un objetivo específico. Entonces, teniendo en cuenta lo importante que es la leche humana, la leche materna para este grupo de pacientes, quizás es importante resaltar que prefiere tener un bebé que tome completamente o leche humana exclusiva y que crezca un poco menos a tener uno que crezca mucho y que reciba fórmula.
It's very important that we explain this to the mother. For the parents, weight gain is their visible understanding that their baby is getting better. So they can become worried if they see their baby maybe not on the centile chart properly, and they may decide to stop breastfeeding. So when we think about weight gain, we need to plan nutritional care. We need to explain to the parent why we do things and why sometimes slow weight gain, they do not need to worry.
Maybe not just the parents.
Absolutely.
Lo que dice es que es muy importante que transmitamos a los esta idea, ¿no? de que no es lo importante, la ganancia de peso no es lo más relevante en cuanto a la salud de su bebé. Existe una creencia, digamos, y por eso yo le repreguntaba, que quizás no sea particular o específica en los padres, nada más de que crecer y aumentar de peso es algo bueno, digamos, y la verdad es que si nosotros nos comunicamos de esa manera con los padres, en la medida que quizás no aumenten tanto de peso como ellos quisieran, quizás existe la posibilidad de que cambien de visión y se preocupen más por eso y que busquen alguna otra forma de alimentarlo y pierdan, digamos, ese entusiasmo o esa dedicación hacia la lactancia exclusiva.
Carmen.
Bueno, muchísimas gracias. Bueno, relacionando todos estos comentarios de crecimiento, sin duda, nuestro objetivo es que crezcan, pero siempre priorizando el neurodesarrollo. Surgen en el público las preguntas en relación a qué tipo de curvas utiliza, y esto va relacionado, por eso los pongo juntos, si utilizan medición de composición corporal.
Sí, okay. The questions coming from the public regarding this this contradiction between growth and neurodevelopment, or this probably these differences between growth and neurodevelopment or important outcomes. They are asking which kind of curves for weight gain or for growth are you using, or which curves do you use, and if you also use body total body composition measurements.
Yeah, we use UK growth charts that are based on the WHO growth standards, and the data suggest that growing like the fetus, as is shown by the Fenton curves, is probably better for neurodevelopment than the intergrowth curves?
Bueno, dice que ellos usan unas curvas desarrolladas en el Reino Unido, que están basadas en los estándares de crecimiento de la Organización Mundial de la Salud, y que ellos consideran que crecer como crece el feto, en lo que se basan las curvas de Fenton, probablemente es mejor para el neurodesarrollo en comparación con un crecimiento guiado por las curvas de intergrowth.
But remember, as I said before, that weight gain and growing on a centile is just a number. The most important thing is to continue to promote breast milk even after the baby goes home.
Sí, pero vuelve a remarcar que la ganancia de peso es solo un número, solo un marcador, y que lo más importante es promover la lactancia materna y aún después del alta del paciente de la unidad.
Yeah. Body composition measurement is only a research tool at the minute. There are no clinical measures to assess body composition that are useful in clinical practice.
Que las mediciones de composición corporal son actualmente solamente una herramienta de investigación, ya que no hay ninguna medida que sea útil a los fines prácticos de la clínica.
We should measure head, length, and weight. But if you measure that, there is no advantage of doing anything more complex. Doing DEXA, MRI, bod-pod, skin folds, none of these things have any data for use in clinical practice at the minute.
Si uno mide lo que habitualmente se mide, que es la circunferencia o el perímetro cefálico, la longitud corporal y el peso, eso es suficiente y no hay ninguna otra medición, ni siquiera estudios más complejos como resonancia magnética, que agreguen utilidad a estas evaluaciones en los recién nacidos. Tampoco el skin fold, ¿no? el pliegue, la medición del pliegue.
Muchas gracias.
Thank you.
El doctor Bain nos quiere hacer un comentario en relación a esta charla. Adelante, Coco.
Primero, me parece espectacular la charla y lo que quiero remarcar es la calidad de las respuestas que nos está dando el doctor Embleton, porque a veces los speakers podemos preparar grandes clases y grandes conferencias. Un buen docente neonatólogo puede hablar excelentemente de fiebre reumática en el adulto si lo prepara bien, pero contestar las preguntas como él lo hace me parece que tiene un valor extra. I just mentioned, Nick, that we are very glad that you are participating in this discussion in the way you do with so clear and so direct answers of your own experience, and that a good teaching person, a good teaching neonatologist can give a great lecture on rheumatic fever in the adult if he prepares it, but to answer the questions the way you do, show you your participation in the unit in the way you work. Yo creo que hay dos mensajes que quiero remarcar, porque claro, los dio en la charla y todavía no hubo preguntas de esto, pero quiero remarcar dos mensajes que son de la lucha diaria. Una, cómo él insistió en la importancia en que aumentar a mayor velocidad la nutrición puede permitir que en 5 o en 7 días un prematuro extremo después del tercer día de vida esté llegando a la alimentación oral completa, y que eso no demostró aumentar el riesgo de enterocolitis necrotizante ni de ninguna complicación, y que la importancia que eso tiene, lo mismo que la importancia de estandarizar para que todo el mundo alimente de la misma forma y podamos ver después si eso, y si estuvimos bien o estamos mal o tenemos mucho o poca enterocolitis. Si cada uno alimenta como quiere, no se puede interpretar. I just mentioned enhancing the subject that you mentioned before of not going so slowly, and that to standardize the way we feed in order to later know how that impacts in complications. And then, now the question, ahora la pregunta sería, desde el momento que alimentamos tan rápido, muchos pequeños prematuros están sin vía después del día 10 o después del día 12 hoy día. Entonces, yo pregunto, ¿cuál es el impacto? ¿Qué se sabe del impacto de las medicaciones? Porque ahora muchas medicaciones pasan a darse por vía oral, que en otras épocas que teníamos 3 semanas o 4 a los chicos con parenteral, se las dábamos por vía endovenosa. Si hay algo que peor, o si hay algo que pueda haber sido identificado como un problema para el uso de medicaciones orales, cualquiera de ellas, los AINES o las vitaminas o los diuréticos, o lo que antes se podía dar por la vía endovenosa.
Hacela en inglés, Coco, dale.
Okay. You know, Nick, the translator say, now I have to translate it. But let me tell you, for the next talk, when Joe Neu gives his lecture, we won't pay them the $10,000 they were going to get in this one.
Yeah.
Because of this. And no, what I ask is that since we are going so fast now in feeding, by 10 days, many of our tiny, very tiny premature infants, maybe 12 days, are without an IV. So we use a lot of medication sometimes, like diuretics or vitamins or anti-inflammatory, non-steroidal drugs, etc., orally. Is that a problem, or has it been shown as a problem, or is it problematic?
Well, is what problematic?
The fact of administering those medications enterally.
Oh, I don't think so. I mean, I've not seen any data to show that giving non-steroidals by mouth is problematic. We occasionally will give brufen enterally if we need to. We often give diuretics enterally, even antibiotics sometimes. So that if the gut is working and you can absorb, I don't see any problem giving these drugs enterally.
Carmen.
La traducción. No, él dijo que no ve ningún problema en administrar este tipo de medicaciones por vía enteral. Si el intestino está funcionando, distintas medicaciones pueden ser administradas, y de hecho ellos lo han hecho con diuréticos, a veces con antibióticos, y hay otra que se me perdió, no sé, Gabriel, si la recordás.
No,
pero dijo también
que
básicamente si el intestino funciona también para absorber esas medicaciones.
Bien.
Bueno, muchísimas gracias. Señalemos entonces, ya que Coco hizo mención a los puntos y esto también que Alejandro y Cecilia lo comentaron, sin duda el valor principal de la leche humana. No busquemos y corramos por probióticos, sino que más que nada para nosotros que somos un país con dificultades de recursos, más que nada concentrémonos en incrementar y en trabajar para favorecer la importancia de la lactancia. Nos están quedando poquitos minutos y me gustaría que tanto el doctor Dinerstein como la doctora García puedan hacer algún comentario o pregunta para el doctor Embleton.
Gracias, Carmen. A mí, digamos, en base a la poca evidencia de favorecer la leche de madre donante, que el doctor señaló, e incluso las revisiones Cochrane en cuanto a los resultados para NEC y para sepsis, y sabiendo el costo que implica poner en marcha los bancos de leche humana, quizás promover que esos recursos vayan dirigidos más a fortalecer el personal que contribuya a la obtención de leche de la propia madre, que en la gran mayoría de los lugares es escasa, es muy escasa. Esto tiene que ver con el número de personal y con el conocimiento. y también con la infraestructura que se les ofrece a las madres para poder extraerse leche. Sabemos que no está uniformemente distribuido el acceso a bombas extractoras de leche en todos los lugares, sobre todo en los lugares donde tienen un predominio del nacimiento de bebés prematuros. Entonces, bueno, creo que merece tener una reflexión al respecto en relación a la prioridad que se le está dando. Los que lo tienen, bienvenidos sean los bancos de leche, pero los que no lo tienen, por ahí promover más la dirección de los recursos hacia obtener la infraestructura de personal y de comodidad para las madres para poder extraerse la leche y dársela a su propio hijo.
Pues yo, Gonzalo.
Bueno, gracias.
Dr. Garcia wanted a reflection from you, Dr. Embleton, regarding the, considering the scant evidence regarding the benefits of donor milk, or that these benefits are probably not that convincing, and the cost that is implicated in mounting and organizing a milk bank, a human milk bank. Probably it would be an alternative in countries such as ours to promote that these resources could be used to promote and to increase the personnel and the infrastructure and equipment required to obtain human milk and to obtain lactation from the mothers of, especially in the places which receive a lot of premature babies and premature patients. And in this sense, she would like your comment regarding the priorities. The places that already have built banks probably go ahead and use it, but maybe if today in countries such as Argentina, should we prioritize the creation of more milk banks, or should we go to policies that stimulate and promote the lactation from all mothers?
That's a very important question. I'll start by saying that the evidence for the benefits of donor human milk largely come from trials conducted in Europe and North America. And we should always be a little bit careful about extrapolating that data to other countries.
Sí, comenta el doctor en respuesta a la pregunta, al comentario de Cecilia, que subraya que le parece sumamente importante lo que comentó Cecilia, que la evidencia de los beneficios de la leche donante proviene de estudios fundamentalmente realizados en Europa y en Estados Unidos, y que hay que ser muy cuidadoso en extrapolar esos resultados a otros contextos, a otros lugares.
As doctors, we have a duty to consider cost effectiveness as well as clinical effectiveness. So we must be thinking about the question that you asked: what is the best strategy?
Claro, nosotros como clínicos tenemos que estar, o estamos obligados a considerar no solamente la efectividad clínica de las terapias o los tratamientos o las estrategias terapéuticas, sino también el balance costo-efectividad. Y entonces ahí hay que hacerse esa pregunta: ¿cuál es la mejor estrategia? ¿Cuál es la más efectiva? Pero también haciendo un balance de costos y beneficios.
And the way to answer the question is for you to collect data in your own settings. In your hospitals, you need to do studies to determine whether using donor milk may be effective in reducing necrotizing enterocolitis, or may be effective in supporting the mothers, because the context of your country, your mothers, your babies, your nutrition is different from mine. So what's may be good for me in the UK may not be good for you in Argentina.
El desafío es desarrollar datos propios, teniendo en cuenta nuestro contexto, nuestras estrategias, nuestra población, y entonces ver, nosotros tenemos bancos de leche en nuestro país, juntar datos y poder evaluar o investigar si en nuestras poblaciones, en nuestro contexto, el uso de leche de banco es efectivo, disminuye ciertas enfermedades, como se ha mostrado en otros contextos, y si realmente es también costo efectivo. Thank you.
Bueno, muchísimas gracias. Ahora entonces Alejandro va a hacer un comentario, una pregunta, y luego finalmente el doctor Pruden hará una pregunta, comentario y el cierre de este encuentro tan importante, así que agradecemos mucho las participaciones y algunas preguntas que hayan quedado en el tintero, luego nos comprometemos a responderla al resto de los participantes.
Sí, yo quiero tomar algo que para mí es fundamental, que dijo Nick, que es el rol del equipo de salud en lograr que las madres de nuestros pacientes ofrezcan precozmente leche humana para alimentar a sus hijos, desde calostro y más allá. En muchas unidades, en muchos lugares, los neonatólogos se han retirado, han dejado de lado lo que es la nutrición, lo que es trabajar con los padres para tener una adecuada nutrición en manos de nutricionistas, puericultoras y otros miembros del equipo de salud que colaboran, que está bien que exista y que tienen una función. Pero lo que yo marco es la importancia que tiene, que marcó Nick, yo la palabra del médico, lo importante que es durante la guardia ir a hablar con cada madre, llevarle los elementos para que logren extraerle, y hablar, informar. Todo eso queda mucho de lado. Nosotros hacemos un pase nutricional por semana en nuestro hospital y cuando preguntamos a cuántas horas la madre tuvo su primera extracción de leche, muchas veces nos sorprendemos del tiempo que pasó entre el nacimiento y el momento de la extracción. Y cuando preguntamos en el pase si alguien habló, si alguien informó, esa madre siempre había mucho trabajo, estaba muy ocupado en el medio de la guardia, no, la madre, o sea, hay 1.000.000 de excusas. Yo creo que la nutrición es la subespecialidad de las excusas. No le damos leche por esto, medimos residuo por esto, suspendimos la alimentación por esto. Bueno, me parece que los médicos tenemos que hacernos cargo de lo que nos toca, de lo que nos corresponde, que es tan importante como ventilar un chico, como pensar qué droga inotrópica, como ver qué modalidad respiratoria es garantizar el acceso a la mejor nutrición de nuestros pacientes.
Pues yo, Musa.
Dale. No, está bien, yo no traduciría eso.
Es un comentario.
Claro, yeah. Un comentario.
Okay. It was just a comment. It was just a comment on the importance of nutrition and how frequently the people is very much aware of the ventilatory situation, the drugs or cardiovascular things, but don't think as if it was so important nutrition, and it is.
Yeah.
Okay.
Bueno, damos lugar entonces al comentario y pregunta para cierre final del doctor Luis Pruden. Muchas gracias.
Nick, how successful have you been in eradicating the habit of giving importance to measuring gastric residual volume? Pregunta, ahora la hago en castellano. ¿Cuán exitosos han sido en erradicar la costumbre de darle demasiada importancia al valor del residuo gástrico, de la medición del residuo gástrico que tantas veces interfiere con una adecuada nutrición?
Yeah, it's the same, the whole world. Every country you go to has this problem. People like to check residuals. The nurses like to show me green secretions. I look interested and smile and tell them to put it back in the baby and carry on. I think it's no different in my country to your country. So yeah, I try and encourage people not to do it too much, but when you go home at nighttime, they still do it.
Sí, con la respuesta es que es lo mismo en todos lados, que lo ha visto en diferentes países y en diferentes ambientes. Muchas veces a la enfermera le gusta mostrarle un residuo, a veces un poco bilioso, y a él pone, uy, qué importante, póngaselo de vuelta en el estómago, y que le parece que no es diferente en muchos lugares del mundo, que más allá de que ya sabemos que no es tan importante, es algo que bueno, que sigue ocurriendo, ¿no? Que cuando se entra a la casa y a la noche lo van a seguir midiendo.
Bien, yo un solo comentario. Cuando Nick presentó los datos con la evidencia de los probióticos, recuerden que en la conferencia él dijo claramente que esto no era extrapolable, que en lugares de bajos recursos era algo que debía evaluarse. Y Alejandro Dineste destacó y dijo, ¿qué pasa si un chico recibe leche de madre exclusiva, si eso no es suficiente probiótico? Y esa pregunta quedó flotando, pero creo que como nosotros tenemos que saber que la evidencia que hay de probióticos que presentó Nick no es aplicable a nuestro medio, y yo no he visto estudios que ratifiquen esa información, de manera tal que lo dejamos como un signo de interrogación. Como el tiempo ha transcurrido muy rápidamente y la dinámica fue extraordinariamente ágil, y agradezco muchísimo las fantásticas traducciones de Gonzalo y Gabriel, tengo que dar por cerrado este debate y este intercambio. Nos quedaron muchas cosas, pero lo que ha dejado Nick Embleton es una absoluta sensación que lo central en esto es que todos tengamos conciencia que nuestro rol para promover la lactancia de las madres en los prematuros es central, y que debe ser tan importante como todas las cosas que hacemos de terapia intensiva, junto a las drogas vasoactivas y todo lo demás. Y en cada una de sus frases esto está enfatizado, de manera tal que creo que el cierre debiera ser, bueno, ¿qué aprendimos hoy? Y bueno, lo que sabemos, pero no hacemos tan bien como debiéramos, y que todos debiéramos esforzarnos en llevar a la práctica lo que tenemos la conciencia, pero que en la práctica es tan difícil. Esto que señaló Cecilia, de extraer calostro desde antes del nacimiento, de estar con la madre estimulándola, sin sobrecargarla. Recordemos que tampoco es nuestra misión a una madre que está con un chico prematuro y en situación de estrés ponerle demasiadas responsabilidades, pero con tacto y con afecto, explicando la importancia, creo que nosotros podemos hacer mucho para mejorar la nutrición de estos chicos, sin llegar a cosas de gran complejidad ni usos de fortificadores y suplementos, etc. Nuestra principal responsabilidad está puesta en que todas las madres se saquen leche y que se use la leche de su propia madre en cada prematuro. Así que bueno, yo agradezco mucho al doctor Embleton, al panel reactivo, a los que tradujeron y además intervinieron tan activamente, y junto con Coco estamos muy satisfechos de esta interacción de hoy. Esperamos en la próxima con el doctor desde Estados Unidos seguir en esta tónica, mejorar lo que podamos mejorar de lo tecnológico, que hubo algún problema, pero creo que no fue mayor, y los esperamos para el próximo y les vamos a comunicar por la misma vía. Así que muchas gracias a todos y que tengan muy buenas tardes.
Gracias. Muchas gracias.
Thank you, Nick.
Muchas gracias.
Welcome. Thank you, Nick. Thank you very much.
Thank you.
Thanks.
Thank you very much.
Thank you very much.
Thank you.
Gracias.